Pain is a signal, not a diagnosis. For decades, the medical establishment and the insurance conglomerates that fund it have forced us to chase a single source generator. They want a neat, billable entity, a single herniated disc, a single trapped nerve, a single point of failure. It fits perfectly into a spreadsheet, but it fails the human body entirely. If your treatment plan is built on finding one smoking gun, you are being set up for failure. We are treating the body like an industrial machine where you swap out a part and call it fixed. This is the old disease model, and it is fundamentally incompatible with how complex living systems function. When you force a multifaceted human experience into a binary box, you ignore the reality of human biology. Here's the contrarian reality that most providers will not say out loud. Your medical care is being dictated by administrative necessity, not clinical excellence. Insurance models operate on a binary logic. They demand a single localized diagnosis to authorize a procedure. The system is designed to identify one source generator. If you have nerve entrapment in your carpal tunnel and you also have arthritis in your thumb carpometacarpal joint, the system creates an administrative wall. You cannot bill for systemic dysfunction. You must pick a code. You must pick a lane. If you attempt to bill for the complexity of multiple simultaneous causes of pain in the same anatomical area, you face denials. The system does not pay for nuance. It pays for boxes. Consequently, the medical model incentivizes physicians to stop at the first, most easily billable diagnosis, even if that diagnosis is incomplete. This is why you are offered a surgery or a standard steroid injection for one issue, while the underlying terrain, the web of ligamentous laxity, metabolic inflammation, and mechanical instability, is ignored. They are fixing the gear, but they are ignoring the engine. Look specifically at the hand. We see patients daily who have been told they have carpal tunnel syndrome. They are given a wrist splint, maybe a cortisone injection, and sent home. But consider the clinical reality. A landmark study by Florek et al. In 1992 demonstrated that the coexistence of basal joint arthritis and carpal tunnel syndrome is not an anomaly. It is a clinical expectation. They occur together with staggering frequency, particularly in postmenopausal women and patients with metabolic dysfunction. Treating one without the other is an exercise in futility. If you decompress the median nerve but ignore the mechanical instability of the first carpometacarpal joint, the compensation patterns in your hand remain. The pain returns or it shifts. Diagnostic tests have reinforced this trap. We rely on the grind test, which has significant limitations. Evidence now shows the pressure shear test offers superior diagnostic accuracy, reaching 98%. Yet how many clinics utilize this? Too few. They stick to the tests that fit the billing codes. If the test doesn't fit the reimbursement model, it isn't part of the routine. You are being diagnosed based on the limitations of the office's billing department, not the reality of your anatomy. The human hand is a series of interconnected lever arms. It is a network, not a series of isolated pipes. When the CMC joint, the universal joint of your thumb, lacks stability, your body does not just accept the pain, it compensates. It shifts grip mechanics, it alters tendon tension, and it places chronic, unnatural stress on the median nerve. This is where the assembly line model falls apart. Research suggests that while splinting can provide a moderate reduction in pain, it is a supportive measure, not a curative one. To achieve sustainable relief, we have to audit the entire terrain. First, structural integrity. Is the CMC joint degenerating? Second, nerve health. Is the median nerve suffering from chronic friction or inflammation? Third, connective tissue repair. Is the ligamentous architecture failing? We have moved beyond the age of guesswork. Ultrasound-guided intervention allows us to visualize the entire landscape of your hand. We can see the nerve, the sheath, the joint, and the surrounding ligaments in real time. We don't have to guess based on an outdated single-source exam. True pain management is not about hunting for one culprit to satisfy an insurance spreadsheet. It is about restoring the mechanical and biological environment of the hand. When we treat, we use ultrasound guidance to address multiple targets. We utilize hydrodissection to separate the median nerve from restrictive tissues. Look at the evidence. Meta-analyses consistently indicate that platelet-rich plasma offers superior long-term improvement compared to traditional steroids, specifically in the 6 to 12-month window. We aren't just masking the pain, we are facilitating a biological response. We are providing a foundation for healing that actually respects the complexity of your anatomy. We don't just treat the carpal tunnel, we treat the hand. We aren't hunting for a single point of failure, we are repairing the network. The message is simple. If you have been chasing one diagnosis and are still in pain, you aren't looking at the whole system. The industrial model of medicine, the model that prioritizes a single billable code over your long-term function, is the primary obstacle to your recovery. The hand is an interconnected masterpiece of engineering. If it's broken, treat it like the network it is. Stop looking for the one thing you can blame and start fixing the things that actually keep you moving. If you want to move beyond the assembly line, you have to choose to audit the entire terrain. Stop accepting the single source myth. Your body isn't a billable entity. It's a living system. Treat it accordingly. I am Dr. Padda. Welcome to PainMD.tv.